This is LA County again, SPC, statin adherence. Again, all blues for LA County. This is CHW region up north, Northern California. Again, these measures in CHW regions for the same measures. Some of the Medicare activities that we have, so we talked about the joint operation meetings with the groups, provide education. There are a lot of newsletters that go to the providers. There are a lot of there's a lot of member communication that happens that talks about, hey, if you have all these conditions, please ask your doctor about these medications. A lot of these activities have always taken place, and it's not a surprise. A lot of health plans do a lot of busy work. But we have started to now see the impact of all these activities. So there was an intern from UCLA who actually compared all the member communication that goes out and kind of tried to measure the effectiveness and graded them, and is actually now suggesting the few that we should select that are probably more effective than the others. I mean, you would think it's not a big deal, but the printing costs of some of these are huge.
Yeah.
And then some we're turning into more interactive app kind of things than the males. These are the incentives we offer. So we actually offer several incentives to the members for coming into the clinic, for getting the service done. We offer incentives to the providers to call the members in to get a lot of these HEDIS measures closed. This is interesting. This is UC Berkeley. And now a lot of other people are doing this, like Welsh Allen, etc. These are retinal cameras for diabetic retinopathy that we identify the sites which are the sites that would benefit the most with the density of membership, the density of diabetics. So usually they happen to be FQ8Cs. Their cameras placed in these FQ8Cs, and we pretty much pay for the reading of those films with ophthalmologists that are at UC Berkeley. The reason this has worked well, and just a word of caution, is a lot of people are doing this, but the quality of films and the quality of reading is important, and this is pretty much proven very beneficial, and a lot of medical groups and HealthNet is using this. We talked about the incentive. These are some of the tip sheets that go out to the providers. It kind of lists the codes that they should be using to get that incentive or the credit. We did the MPM initiative and kind of actually drilled down into the root cause analysis of why things weren't working. So providers weren't getting credit, or like Scott said, why do we need that supplemental data because the codes aren't coming through? So just because a patient's been to a doctor and gotten a service done doesn't mean we get that data. There's several layers for who's in the industry would be aware. There are many, many layers that go through with the doctor doing the service, the member showing up in the lab, the provider coding for it correctly, for it clearing the clearinghouse and then making it to the health plan. And we don't know if it's done until we get that whole, the coding and know that service has been provided. We have, so these are some of the activities for Medicare. Again, some of the slides for the same measures. This is the CDC measure for the Medicare population now. And this is actually not divided by county, but so it's for the entire state of California. Again, blues are good. So quite a few blues. This is for controlling blood pressure. Again, we have a blue. This is at MPL for beta blocker. For statin, again, we are over 75th percentile. What I noticed is that there are very few measures that we've actually been on the decline. So if there are measures that we haven't hit the MPL, we pretty much stayed there. And that's what's interesting to find out. Whatever activities are going on, what is effective, what's not. Should we change the way we're doing things instead of just that automatic print command going and thousands and thousands and millions of mailers going out there? So some of the Medicare activities that we have, a lot of them listed here. We do have med adherence calendars that are sent to all the Medicare members. We have tip sheets, we have webinars, we have Ivr calls. Take Charge of Your Health is actually pretty good, which is again a self-paced online coaching program for the member that kind of makes them set their goals and then tracks it and sees what is that's motivating the member to. This is what it looks like. It is available to all lines of business. So it's Medicare and commercial, but now it's to all lines of business. We have Ivr calls. The one that I like, so that's, let me see where that is. The one thing we've done well now is the CVS Health Tag. I think I may not have that slide, but essentially what we've done is every time you go to CVS and collect a medication for any reason, if you're diabetic, you will get a little, you get that envelope and you have that little tag. So we've now started talking about the cardiovascular bundle on that CVS tag. It's not a very long thing, it's just 5 sentences, so people just coming into the car, wouldn't mind reading the 3 to 5 sentences. It just says, I know you're here. So if they have collected metformin, it will actually say, hey, if you have diabetes, hypertension, please ask your doctor about aspirin, statin, and ACE/ARB. And you think that's easy, but to get that moving and help that has been amazing. So that's now going to all diabetics, all hypertensives that are picking that up. So commercial marketplace, similar graphs, a lot of blues again here. This is for PPO, HMO, EPO market, but again, a lot of blues. And our membership is changing and transitioning and fluxing, so we don't carry the same population year after year. So we do get a lot of new population, especially through ACA. Centene is very big, HealthNet is very big in marketplace, and this is the transitioning population. So we do get people with pent up demands, with bad metrics, that we have to get them through the process. And these are some of the commercial activities. So the new ones are the ones we've just started. We've started some bi-monthly magazine subscription mailing for ADA for the diabetic members, which was new. This is new, so we've started sending mobile care alerts as compared to mail care alerts for med adherence, for statins, ACE/ARBs. So you would get mailer, but you'd also get a text message, which I think sometimes is more effective. Of course, the AHA Target BD award was new.
So you have new care alerts for RCI-shaped members on med adherence. Can you just elaborate?
Yeah, so that's the one. We have a vendor, Optum, that actually has the entire denominator that I was describing in their database. Whoever drops out from getting a refill of that medication that they have been prescribed gets a care alert. Do you remember you still have to take your ACE inhibitor? You don't have a prescription, ask your doctor. So they're getting care alerts if the pharmacy data shows that he's gotten it from Jan to June and now suddenly there's no claim coming through. They're the people who get the care alerts saying, do you know you're supposed to be on that medication? If there's any way in the future to get hold of these members, it's through their phones. It's through their iPhones and cell phones. This is something that we measured, again, effectiveness of Ivr calls versus live calls. I don't know. Scott mentioned something about pharmacy text, and so live person always better than Ivr calls. Ivr calls, I realize, come in various shapes and sizes. You have the automated, then you have the human-like voice, you have the voice that responds to anything you say. I think live person is a live person, so we know that's the most effective way. So the highest risk members have been stratified, and so that bucket gets all live calls through our coaches. The Ivr calls are for the members who are showing 24 months of adherence, are likely not to be adherent. The Ivr call goes in there and checks on them whether they're going to be adherent. Okay, so this is a clear communication project. Now, this happened in 17. We have an updated version. So what we're doing now, and I was going to tell Hattie about this, is out of all the membership we've seen in diabetics, we've now started to see what ethnicities are likely to be adherent versus are not adherent. We have arrived from our data of about 200,000 patients. The API segment is shown to be
The what segment?
the Alaskan Pacific Islander population, so Asians, Koreans, Vietnamese, Chinese, Koreans are tending to be less adherent to the cardiovascular bundle, despite having the diabetes, hypertension, coronary artery disease. So we are actually launching or kicking off a pilot with 2 provider groups. One is FQHC, and one is a IPA that's very strictly Korea-found IPA, and trying to see what interventions would work. So this could be cultural. This could be just because they don't get communication that's in their right language. This could be because the coach who's calling them is not speaking in the language that they should be communicated with. And so that's just getting kicked off this month. Some of the people are here who are kicking it off. And we're going to see a change to see if that's what's going to move the needle. You know, relating to the member culturally and understanding the barriers, is that what's going to move the needle? So that's just getting kicked off.
That is a wonderful initiative, and we're loving your data, but we have some medical groups here that I'm sure would love to ask you some questions.
Sure. I am finished with my.
Perfect timing. Perfect timing.
So any questions?
So you said this kind of quickly, and I'm not sure I understood. Do you actually have pharmacists calling patients and prescribing medications directly?
So we have pharmacists that do most of our med adherence calls, along with those 6 years measures. So they also take care of the beta blocker, and so they are dedicated to our initiative. So yes, they do see if you have the prescription with the member. Is there a roadblock in the member getting that prescription? Do they have any concerns about side effects, interactions with? Do they understand what that medication is? Do they understand the dosaging? So yes, those are the coaches. Now, all the coaches are not pharmacists. A lot of the coaches are also diabetic educators, nutritionists, because we do want to get through that whole 183,000 membership. But they know how to funnel the calls to a pharmacist if that's needed.
Okay, but they're not prescribing.
No, they're not prescribing.
Okay, because I thought, it sounded like you had said that at one point.
They're not actually
But that could be
prescribing.
right,
Not,
okay.
no, not yet.
Okay, thank you.
John?
Thank you very much. I found that fascinating, really interesting. I have so many questions, but let me just keep it to 1 or 2 for the moment. One of the things I was doing was contrasting this with the earlier speaker from Kaiser and thinking about in what way some of your approaches were different and what was similar, and how much of that was due to the population being quite a different population. And also thinking about the 40% versus 90% kind of, did I quite understand this, that your ambitions were much lower because you've only just started and because it's a different population? Okay, so exploring that.
It's a combination.
One last thing though. Is some of the differences to do with you're making more use of health coaches? I was also very interested in how much the online was working for that particular population, because you mentioned that. And related to the last question, I still wasn't terribly clear. Are you making as much use of the pharmacist as was stressed to us by Kaiser? Or are you just using them for a particular group? So, you've got about 10 questions.
That's okay. Now, you deserve it. You came a long way. The first question, Kaiser is a very, like I said before I started, it's a very integrated, inclusive model, which means not only do they have all the sources of data and information in one place, but all the touch points also housed in one place. The population that Kaiser has is also very different than what we have. So we have exchange, we have Medis, we have Medi-Cal. But I think we are trying to collect and see all the sources of information that we get. So Kaiser pharmacy, Kaiser member hardly ever goes to an outside pharmacy to get a medication. They all get it in Kaiser. They have the perfect data, they have real-time data. We have to get it from all kinds of sources. This is just one of the challenges. There are many different kind of challenges. They probably have a much more robust member contact information than we have. So we have a challenge of a very transitioning population with bad demographic data, us not being able to reach these members. So the challenges are a little different. So they have been able to make an impact because of all those factors that they have the privilege of having. We're trying to engage with members, but we have to spend and get additional resources to have coaches engage with our members. The online engagement as well is a little new, so I'll give you an example. If a member is part of a PCP's office, now if it's a really 5-star fancy office that you're in, they will have their own patient portal and ways to engage with the member online. So the member has exposure to that, the member has exposure to the health plan and a portal and what we're trying to do. So it gets a little confusing for the member to go.
One quick last one, sorry Hattie. On the costs, what are your plans to develop the way in which you do the cost assessment? You left it by simply, you were saying, well actually we're just focusing on changes in cardiovascular events. Utilization, do you have any knowledge about how you're trying to deal with the costs?
Yeah, so we have something called a PMPM cost, right? Per member, per month cost. Now that's all costs. If you were to use any healthcare resources or ER or emergency room or had an accident or had an asthma attack, it's all that cost. What I was measuring and trying to track is the cost that's directly related to your cardiovascular condition. So if you're going to the emergency room or the urgent care or your doc just for your cardiovascular condition, that's the cost I was looking at impacting.
And you're able to track that?
I'm able to track that, yes. Yes, all this is an effort. It's a one-off effort. It's not something that we get automatically. So our data analytics team has to be given a whole set of codes, and the algorithm has to be developed so that the cost is coming accurately. And for different lines of business, it's different. So yes, and then your third question was the pharmacist. The pharmacist is an evolving process. For us, unlike Kaiser, we have a Centene subsidiary company that does our pharmacy work. So it is a subsidiary company with a separate cost head and a profit center head. And so to get the pharmacists hired and do the job that we want them to do and be dedicated to your initiative is a little different than how Kaiser would have it. But right now they're just doing the coaching calls, explaining to the member why they need to be on the medication, addressing their medication questions, clearing up their medication confusion questions, not prescribing and not titrating yet.
I'm sorry, I do have a naive European observation. For probably a very challenging group of members that you're covering, what is it that you're doing that can help you expand and keep in business like this? I mean, some people would say this is exactly what we want to avoid. But again, that's a naive European.
No, so what we're trying to do is, there are different ways to make a difference in the population health, right? So you have a lot of sickness out there. You have a lot of comorbid conditions. You have these members who are the highest risk, who have 3 highest risk comorbid conditions and wouldn't take the basic cardiovascular bundle. So we start from the member, we say, do you understand what you have? Do you understand why are we trying to do what we're trying to do? Do you understand all the other lifestyle factors? Do you want to just be online and talk to Omada for exercising, wellness, and diet? Plus, you have a doc that's trying to prescribe you the medication. What can we do for you to adhere and keep taking those medications? So can we make it easy for you to get the medication? Can we decrease the cost for you? Can we clear any doubts you have on the side effects? Do you have any questions on the interactions of all these medications? So the purpose is to get the member to be motivated and convinced and educated enough to stay and adhere by not just the lifestyle, but also the medication. That's the only way you're going to make an impact, right? Just bombarding them with a phone call or a prescription isn't going to do it. Does that answer your question?
No, it doesn't. I said enough.
So I just want to make sure that we hear from people who haven't spoken yet first, before we hear from somebody who's already spoken. If anybody is shy and wants to get in, okay, so we have, could you say your name, please? Amanda Calvert from Blue Shield.
So one of the challenges that you described was member abrasion, and also coming from a plan, I am wondering, how did you manage that? At the plan level, there are many teams that are also trying to touch the member. And then also, also when you're working, does the group have a say? Did you need to convince people to opt in? Are you working on it collaboratively? How do you make sure that, we're keeping the member happy with strategic messaging? Because I know that there's a lot of competition to, get your message across.
So Amanda, you understand where we're coming from. I don't think we've perfected it, but I'll give you an example for the rest of you who don't know who could be getting in touch with the member. So it could be a PCP's office calling about scripts, about medication. It could be the IPA or the PPG who's making out calls, a pharmacist in the PPG, could be quality in the PPG. And then you have the health plan. And then you have these vendors that health plans work with who sometimes work in isolation and have their own list that they're calling. For different lines of business, there might be actually more vendors. So Amanda, you understand the vendors who do HRAs, right? Customer center, we have health head, we have cultural linguistics. It is difficult. We had about 12 departments that we identified, or 12 touches that we identified just internally in our health net that were calling that same member. This was apart from the PCP and the group. So what we usually do is when we go and take this list to the group, we say, this is where our value add is. Is there anything that you're doing? So I work with UCLA, and UCLA said, I'm sorry, Jean, hands off. We got this. Give us the list. We have our own pharmacists. We have our own registries, and we are doing this. So I was hands off, and we're just monitoring their numbers, right? So the point is, if you have the relationship, please go ahead. All I need is my numbers to look better. They're at 90-something compliance rate. So it's very important to collaborate with all the touches, which is very special to California with the capitated groups. I don't think we're perfect. I still think there's a lot more aberration happening, but I think it's just lesser.
I have a question, and that is of the audience or of the people who've been listening to the health plan presentations, the physician leaders in particular, how is this working for you? Christine, I'm looking at your body language, and I'm thinking, we'll talk about that later.
So, I think, and I had to kind of smile with Amanda asking that question because we've been around this block a few times, At Healthcare Partners, we're very lucky. We're a big integrated system. We've got lots of infrastructure around all this stuff. my team's put a lot of thought and effort into these types of programs. We have a team of pharmacists, and we're using them. So, you know, my concern when I hear these types of talks is, oh my God, I hope you're not doing this with my patients. And I actually checked with my team, and they said you're not. So, or if you are, you haven't told us.
And I think you and I will agree is it's easy when they're a high
Right.
performer,
Right.
and then you know that something
Yeah.
is already in place.
But a lot of people don't have big honkin' infrastructure like we do. In a lot of ways, we're more like a health plan in that regard.
Right.
So the fact that you guys are able to provide this for groups that can themselves is awesome. But I think you're right, it's that negotiation between what does that group need? What can you guys provide? And then what places are we all gonna be tripping over each other, and we need to figure out who's gonna do what?
For healthcare partners, I know for a fact, they went with the list and they did say pretty much the same thing. We've got this, we will reconcile your list with ours, check if we have any different data than yours. There are groups out there that do not have that infrastructure or support, and there are many of them. Now, the one segment that we are forgetting is those fee-for-service doctors, who are the one doc down the street with absolutely no support, with the knee survive at the front desk, right? They are also getting these lists. When they get these lists, they get a toolkit with them, so the PR reps are the ones right now taking those, but they have a toolkit that says, hey, this is Jim Duddle's study, because docs are evidence-based. This is why we're doing it. This is how it affects you. PR reps do it, and then we have something called practice transformation coaches as well. They are doing it as well. But we are going out with these lists. So for a doc, if he really cares about his patients, he's going to pay attention to that list and say, oh my God, I had no idea. Because you know, when you're seeing 20, 30 patients a day, this is not at the top of your mind. So it's nice to have that list, very succinct list to say, hey, just can you check they're on these medications or not.
So I'd like to hear from more of the physician leaders in the room about how this is working for you. To have the health plan doing the direct outreach with the voice recognition, et cetera. I can say as a patient, I was really unhappy when I got a call from a pharmacist who didn't know what they were talking about on behalf of a health plan, saying I hadn't picked up some medication, which was just not good information. And it felt incredibly intrusive. So I think it needs to be handled delicately, and especially in this era where we're getting all these calls from, who in the world is calling us, right? If it's my Dr. Joy is calling me, I will absolutely take that call. But if it's an unknown number, it's going to voicemail.
Right.
And it may be a huge waste.
That's one of the reasons, I'm not very big on pharmacist calls. They're great at titrating and handling the medication, but when it comes to really gauging, so before I chose the vendor, they're called Healthy Pathways, I was a dummy customer for them, and I was the nastiest to them because I said, I know I have this problem and I'm not gonna listen to you. And I was trying to see how they push me, and they were very, very calm and very, they wouldn't push me, they would let me go, then they would say, when would you like to go? Would you like evenings? Would you like mornings? Why don't you just start walking 10 minutes down the street if you think your calendar is crazy? They were really good at motivating me on the lifestyle. Not on the medications, not on drumming me on my lab tests, but on the lifestyle. So walk more, eat healthy, eat frequently. And so I liked them a lot because they were diabetic educators or nutritionists or dietitian or wellness coaches. And they could push the member as much as they wanted to be pushed. And then they got to the real deal, which is let's now figure out your blood pressure and your sugar and I was like, oh, I don't have any of those, I was just fooling with you. But they were good.
So, Dr. Peter Konishigi, did I say your name right? Thank you for making that big trip to come up here. So we'd love to hear your perspective.
So actually, I work for Memorial Care. I think this is my first time in one of these meetings. And I think one of the reasons I was asked actually is because my office from Memorial Care is actually the closest to this place. It's in Torrance, whereas every other offices are in Long Beach or in Orange County. Been in practice for 22 years. I started in a small group.